So let's talk about pain assessment. It is fundamental, as you said, to talk about pain. It is fundamental to detect and manage pain, I would say even in critical illness, and it shouldn't be considered as a cherry on the cake because we have to provide a humane and ethical care. And what is the cherry on the cake is that the better pain management is associated with better patient's outcome because pain is a body alarm and its assessment allows for better detection, associating with the global disease management, a reduction in adrenergic stress response, a better match between opioids dose and patient's needs, a reduction of sedatives and paralytics, and eventually a reduction in mechanical ventilation, duration, and length of stay. And it is why we have to provide in the modern ICU a comfort using analgesia, a minimum of sedatives and a maximum of humanity. I think that you agree with that because it's a concept developed by Jean-Louis Vincent and colleagues. This was, you know, the concept you developed, the ECASH concept, maximum comfort analgesia, less of sedatives, and maximum of humanity. So for the assessment of pain, you can ask your patient if they have any pain or ask them to rate a number on the pain scale. And there's a strong difference between these two approaches because a patient could answer, no, I have no pain, or no, do you have any pain? No. And finally, give a 6 on the pain scale. And in this paper, the ICU Management and Practice, we describe several common cases where a patient would answer no, but eventually give a number. And some of them are critical. For example, this patient who underwent a surgery 2 days before, and you ask him or her if they have any pain, and they say no, and I'm very surprised because I was afraid to have a severe pain and I have no pain on my surgical site. But when you show this scale, the patient use it rather as a CT scan from up and down and would say, oh, I will give a 3 on my right leg. And you could make early diagnosis of phlebitis. So this scale is much more sensitive. And it was demonstrated in this study. This later scale was the most feasible scale, valid, reliable, preferred scale for the patient with the best negative and positive predictive value than other scale. And the worst scale was probably this one, which is a good scale, but in critical illness with patients who have often ICU-acquired weakness, it is very difficult to move it precisely. So there have many more false negatives in pain assessment with the simple yes/no question, and the NRS is the best scale to show positive results and to make a good diagnosis. And most of the ICU patients who follow simple comments can rate a number of on this scale, and delirium, but not intubation, is a factor associated with failure. So what's about patients who are unable to follow simple comments, for example, because of delirium or sedation? So let me read an extract from this essay on medical iconology, or on the relationship between the art of drawing and the art of medicine, written by our dean at the Medical School of Montpellier 2 centuries ago. The artist should work with physicians in order to represent all differences in the expression, especially of all diverse sorts of pain. And it's why he created 2 centuries ago a fine arts museum at our medical school. And you can see Milo of Croton beaten by a lion with the typical picture of pain. 2 centuries later, the gold standard to assess pain in the modern ICU is a behavioral pain scale that you can use during a procedure, but also at rest. And it is now recommended to prioritize the pain management over the sedatives and to treat pain before increasing the sedatives to reduce the use of sedatives and the duration of awakening and weaning from the ventilator. So in this very short algorithm, in the orange boxes, we have what we ask for the patients who are able to communicate, and the green boxes are the behavioral pain tool, the plan B. And the red boxes are for the patients who have no behavior, for example, the patients receiving paralytics. So we have to use electrophysiology, but mind that the simple vital signs and the monitor are not very reliable in critical illness. And now there are many new electrophysiology tools, such the Analgesia nociception index. And when the ANI decreases, this means that the parasympathetic tone decreases and the sympathetic tone increases, meaning that there's an adrenergic stress response. And the ANI, in fact, detect the heart rate change inducing by the breathing. And we look at the bispectral indexes changes during tracheal aspirations with paralytics and just after recovering from paralysis. And we compare it to the ANI. So the 2 left boxes are the bispectral indexes changes. And we can see on the 2 right boxes that the ANI is much more consistent and reliable and could be a basis for further studies to better assess pain during paralysis. And in some patients, this one who is awake for a very long ICU stay, he developed absolutely no behavior and a severe depression. You can put the ANI, and if it is very low, that means that the parasympathetic tone is very low and the sympathetic tone is high. You could consider giving analgesia and look at the increase of ANI. So we could enter the brain to detect some suffering, but using it case by case. So to summarize, in most of the patients in the modern ICU with the minimum use of sedations, the patients can follow simple commands, and we can use a patient's self-report that it's the very gold standard. The plan B, in the case the patient could not follow commands, you have to use behavioral tools, and case by case, only in case there are absolutely no behavior, case by case, we could consider using electrophysiology.